My name is Dr. Anthony Lemaire. I'm a cardiothoracic surgeon. Today we're going to talk about aortic valve surgery. Before we get started though, let's go over the anatomy of the heart. This is a model of the heart. I like to think of the heart in terms of sides. This is the right side, right atrium, right ventricle, and this is the left side, left atrium, left ventricle. Blood will classically go from the left atrium to the left ventricle, and then the left ventricle will squeeze and push blood to this structure. This is the ascending aorta. It carries blood to the brain up here, and it goes behind the heart and supplies the other organs, the kidney, the liver, and even the extremities. Now, between the left ventricle and the aorta is a valve. It's referred to as the aortic valve. When the valve opens, the blood goes from the left ventricle to the aorta, but when the valve closes, the blood stays in each component. Now, there are several reasons to operate on the aortic valve. The most common is aortic valve stenosis, and that's when the valve is hard to open. In that scenario, the left ventricle has to squeeze really hard to push the blood through to get to the aorta. The other indication to operate on the aortic valve is aortic valve regurgitation, and that is when the blood goes from the left ventricle to the aorta, but because the valve is leaking, a lot of the blood goes back into the left ventricle. Over time, that makes the left ventricle bigger, which is not better. When someone is going to have aortic valve surgery, first they'll go to the operating room, they'll go to sleep, we'll open up their chest, and then we'll get to their heart. We'll put their heart on the heart-lung machine, and then we'll give medicine to the heart so it's not moving. Once the heart's not moving, we'll open up the aorta. We'll then assess the valve. We'll then take out the old valve. We'll size the valve, the new valve, and then we'll put a new valve in. Once we're satisfied with our work, we'll then close the aorta, and then we'll work on coming off the heart-lung machine. Once we're off the heart-lung machine, once the patient is stabilized, we'll close the chest, and then we'll go to the intensive care unit. Now, there are two types of valves that we can put in. We can put a mechanical valve in. That valve will classically last forever, but it will require blood thinners. There's also a tissue valve, which comes from either a cow or a pig, and that will last somewhere between 12 and 15 years, and then it'll have to be replaced. These operations classically last somewhere between 2 and 3 hours, but it could be longer if you're doing additional parts of the operation, like bypass, or if you're doing an additional valve surgery. Most patients will spend 5 or 6 days in the hospital, then they'll go either home or rehab. Now, we do this operation all the time, but there are risks involved. There's risk of infection, there's risk of bleeding, there's even a risk of death. The risk of death averages somewhere between 2 and 3%. But it could be higher if the patient has more risk factors, but also if we're doing additional parts of the operation, like adding another valve surgery. Now, I just gave you a basic description of the aortic valve procedure. If you have any additional questions, please let me know. Thank you very much.